Good evening, everybody. Welcome to Hand in Focus. The theme of tonight's session is on artificial intelligence or AI. I'll be moderating tonight's session together with Carl Abelin. The first article we'll be discussing tonight is entitled Is Artificial Intelligence the Future of Radiology? Accuracy of ChatGPT in Radiologic Diagnosis of Upper Extremity Bony Pathology. And joining us tonight is senior author Shelley Nolan. Our second paper we'll be discussing for tonight is entitled Experimenting with the New Frontier, Artificial Intelligence-Powered Chatbots in Hand Surgery. And joining us tonight is senior author Daniel London. We have two experts for tonight's webinar. Our first expert is Riza Forghani, who is currently the Imaging IT Physician Lead in Advent Health in Orlando and previously Professor of Radiology and Artificial Intelligence at the University of Florida, and certainly a physician expert in artificial intelligence. Our second expert for tonight is Dr. Mei Liu, who's a computer scientist at the University of Florida. She works in the Department of Health Outcomes and Biomedical Informatics and is also Director of Predictive Analytics. So we're going to have a different perspective from her about the use of AI in medicine. So the format for tonight will be divided into two sessions. For each of these, we'll start with the author presentation, followed by discussion and presentations by our experts, and this will be followed by open Q&A. So please mute your microphones, please turn your camera off while the speakers are presenting, and please ask questions because, as in previous sessions, Hand in Focus is really designed to be engaging and interactive. So without further ado, I'd like to invite Dr. Nolan to kick us off. Shelley, please.
Thank you. Good evening, everyone. Thank you for joining us. I have the honor of presenting our work, but I do want to give credit to my co-authors, 5 medical students from Mayo Clinic, and especially to Anika Hiradesai, who is the lead author on this paper. This paper is titled, Is Artificial Intelligence the Future of Radiology? Accuracy of ChatGPT in Radiologic Diagnosis of Upper Extremity Bony Pathology. Artificial intelligence is a promising tool to aid in diagnostic accuracy and patient communication. Prior literature shows that ChatGPT answers medical questions and accurately diagnoses hand and surgical conditions. In September 2023, ChatGPT 4.0 was introduced. This version enabled AI analysis of images. 2 main questions were asked for this study. What is the accuracy of ChatGPT 4.0 when evaluating radiologic imaging of common upper extremity bony pathologies? And does this accuracy vary by imaging modality and type of pathology? In terms of our methods, the imaging was sourced from Radiopedia, and the images that were utilized included distal radius fracture, metacarpal fracture, carpometacarpal osteoarthritis, humerus fracture, scaphoid fracture, and scaphoid nonunion. For those not familiar, Radiopedia is an open source radiology learning resource and database. X-ray, CT, and MRI images were included, and 50 images were randomly selected for each pathology. All images that met inclusion criteria were included for conditions that had fewer than 50 images, which was the carpometacarpal osteoarthritis. Figures were uploaded to ChatGPT 4.0 and queried for imaging modality, laterality, and diagnosis. Each image query was completed in a new ChatGPT search tab. Multinomial linear regression was used to identify variations in ChatGPT's diagnostic accuracy across imaging modalities and medical conditions. The highest accuracy category was set as the reference standard. Here in this image is an example of the a standard query that we would utilize for this study. So first asking, what is the imaging modality? Is this the left or right side, which we utilized for the X-ray images? And then what is the diagnosis? Sometimes ChatGPT would decline to provide a diagnosis in favor of consulting a medical professional. Thus, we recorded the rate at which ChatGPT provided a diagnosis at all by condition and imaging modality. And then we also looked at the accuracy of the diagnosis when provided. ChatGPT provided a diagnosis, not necessarily an accurate one, but did provide a diagnosis for 52% of images, ranging from 27% for carpometacarpal osteoarthritis to 68% for distal radius fracture, as shown in the first column here. ChatGPT was significantly less likely to provide a diagnosis for scaphoid fracture, scaphoid nonunion, CMC arthritis, and metacarpal fracture relative to distal radius fracture. ChatGPT accuracy, so now we're talking about the accuracy of the diagnosis that was provided, ranged from 0% for both scaphoid nonunion and CMC osteoarthritis to 55% for humerus fracture, as shown in column 3. ChatGPT accuracy was significantly lower for scaphoid nonunion and metacarpal fracture relative to humerus fracture. ChatGPT was significantly less likely to provide a diagnosis for MRI relative to X-ray. ChatGPT diagnostic accuracy was 0% for MRI, 30% for X-ray, and 40% for CT. No significant difference was identified in diagnostic accuracy between imaging modalities. We found that significant variation in pathology was present with diminished accuracy for subtler findings such as scaphoid nonunion and CMC osteoarthritis. ChatGPT was able to consistently identify what type of imaging and laterality when present, and thus we know it's capable of appreciating and interpreting studies to provide reads. However, it did struggle with MRI and to some extent CT scan relative to X-ray. Part of this, of course, is the higher level of detail, but also limitation of the slice-based imaging, which is CT and MRI obviously are not typically read in a single slice, and this was we were providing a single image to ChatGPT. So thus the X-rays were single in view, but even then we would typically have multiple views as opposed to just one specific view. ChatGPT would also get confused if there was concurrent pathology present, like a humerus fracture and a rib fracture. ChatGPT would sometimes get confused, and also sometimes it would call a hand X-ray a foot X-ray, for example. So it would not always correct. This iteration of ChatGPT 4.0 is limited in providing reads solely based on diagnostic imaging with no clinical context, especially when compared to models designed for image interpretation, such as convolutional neural networks. And future studies should assess the optimization of search prompts or providing opportunities for iterative learning by training ChatGPT or another AI model on imaging with radiologist reads prior to query. Here are our references. Thank you.
Great. Thank you so much. That was great. Next, I'd like to invite Dr. Liu to give us a perspective on this paper.
Okay, let me share my screen. Okay. I hope everyone can see my slides. I just want to start the discussion with a brief history of AI. Nowadays, people are saying artificial intelligence and machine learning interchangeably, but really they're actually different. AI is not really a new concept. It started really in the last century, in the 1950s. It's a field about, it's more general, about how to make machines do tasks intelligently like a human. So it actually encompasses robotics. Machine learning is actually a subset of a specific field of AI that focuses on approaches that make machines learn from data, so that we do not need to program the machine ourselves. And then deep learning is a subset of machine learning, specifically actually using the neural network models, where it's inspired by the neurons, how neurons work in the brain. So machine learning really flourished in the 1980s, but then deep learning really started in 2010. And what I don't have on this timeline here is actually ChatGPT, which is presented in Dr. Nolan's paper. So ChatGPT is another class of deep learning models, as it's a large language model. well. It's generative AI models, and it was introduced in 2022. And then ChatGPT 4.0 is actually a multimodal large language model where it actually can take image as input. So the original ChatGPT can only take text because it was trained on text data. And then AI and machine learning obviously can be, models can be built to support work of physicians, where, for example, it can be used to build models to help physicians to anticipate future events, like the prediction of high risk patient risk for developing a certain condition, or predicting hospital readmissions or mortality, this is an area that I'm actually working on. This is my research focus. And another area is where you can build model to do diagnosis, help physicians identify conditions that they do not typically diagnose routinely, where you can use image, right? Image analysis-based diagnosis. And another category is where AI and machine learning can help physicians the treatment, where we can help identify a preferred or optimal treatment pathway. For example, chemotherapy, sepsis treatment. And then lastly, but not least, the clinical workflow, where models can be used to help improve data entry with predictive typing, automatic note generation, and note summary. Obviously, ChatGPT can be used in this area here. So this is just a kind of a screenshot of the AI and machine learning enabled medical devices that have been reviewed by the FDA and authorized by the FDA as AI and machine learning enabled medical devices. And so the take-home message from this is actually, as of December 20th, 2024, there are over 1,000 entries in this list. Over 87% of all the authorized devices in 2022 were actually in radiology, and followed by 7% in cardiovascular and 1% in neurology. So we have a lot of medical devices that are AI enabled for radiology. And so the article that Nolan just presented, I think the most important message is actually ChatGPT 4.0 accuracy varies significantly between conditions and imaging modality. So that actually suggests that model generalizability is still poor. So it requires localization with medical data, for example, with medical imaging. So when I build models for clinical risk predictions, what we need to do is actually we need to have a very rigorous revaluation of the model. We need to have, with retrospective data, we need to have internal validation, temporal validation, as well as the external validations. And also based on my experience before, where you also need to evaluate the model across diverse subgroups of patients, because you may see the model performance is different across patient populations with the different underlying diseases. And then obviously, if an AI model is implemented in clinic, in the clinical care, we still need to have a model surveillance, like how we do with the medications, right? When we have a new drug on the market, we still have to do a post-market surveillance of the drug. With the AI model, we still also need to have a post-implementation surveillance. So that's my 2 cents for this here. Thank you.
Great. Thank you so much. That actually was really enlightening for me. So thank you for sharing your experience. Next, I'd like to invite Dr. Farghani, our physician expert, to give some comments about the paper and your thoughts about AI in medicine.
Yeah, so thank you very much. Let me just make sure if you're able to see my screen. I'll give 1 moment. Are you seeing my screen?
Yes, we see your screen.
Okay, perfect. So thank you very much for the presentation, for the study. This is interesting. I mean, it touches on a lot of things, and I was thinking, how do you compress that and discuss some relevant things? But so I thought we would discuss a few things. I always have this just as a disclosure, but I don't think it's really that relevant. I think for the audience, just as a general thing, just this paper using a ChatGPT is a foundation model. Foundation models have really been a turning point. If you think in AI, what are they? They're models trained on very large data sets, and then they can be a starting point for doing other applications. They started as large language models. That was a leap even for those of us who followed the technology. And now they're multimodal, which is very exciting. It means that now you have image to text and more things like waveforms. Now, when we think of these things, when you think of foundation models, what is the exciting part, I would say, as an expert, and if really interesting to see how this has resolved, is that here there was no training, right? Essentially, that was ChatGPT's performance. The performance wasn't good, and we can discuss that. But it's interesting that something that was not specifically trained is starting to have some accuracy. The ideal thing with some foundation models of thoughts is at some point we can use very small data sets to actually have devices that have good accuracy, something that's really important for things like rare diseases. Actually, as it is right now, data is such an obstacle to developing AI. And there's something even zero-shot learning. Can something learn from a single case? So this is the future. So just to give you context, now, what this article touches on is, I think, both the importance and also us not getting hype. The article essentially uses this public device as a diagnostic medical device. It's not doing that well, it's not a surprise. And it actually touches on two things because, everybody always thinks of the diagnosis, and that's great. In radiology, actually, one of our interests is the other part, the reporting. Because if you think how much of our time we spend reporting, and I'm sure our clinician colleagues relate to that in a different way when they're working with Epic and all this time they spend charting. So we can think about the diagnosis, but let's actually step away. And the other thing is that this technology is also going to really help healthcare in terms of efficiency, not make us do charting, things that really take a lot of expert time. And, really, and most people would be happy to reduce both from a cost and other efficiency perspectives. Now, the one thing as a general thing, though, I do want to think sometimes because these things get hype. Yeah, and this was alluded to by other experts. So, I think a lot of people sometimes don't think of regulatory, but actually, if you think of AI, regulatory is a major thing. In the US, software that does diagnosis is going to be software as a medical device or in a medical device if it's embedded in a device like scanner. That's under FDA. The way FDA regulates this is disease by disease. It's actually a barrier, hopefully something that will change. So as exciting of all of these is, even if you forget the performance, you got to realize right now we do not have a pathway for using this medically. Like if you want to actually apply in practice. So just something to keep in mind. There are things approved in Europe under CE mark, for example, that analyze a head CT for 130 things. But in US, they just can't break through because it's so costly to do disease by disease. And if you go to a generalized foundation model, how do you even regulate that? So if we want AI is going to impact all of us one way or another. I don't think the ways that always we think it, but if we use it smartly, it's going to impact us. But if you want these things to come, I think we just also have to think not only what the technology does, but what is that background? Because with the rules right now, these things don't work. The other thing I do say, I did mention the importance for radiology, but I do want to mention one thing. There's the positive side. One thing, and as excited as I am, I really am interested in these foundation models. One thing that does worry me, if you survey patients, what do they do first? They get a diagnosis, they go on Google or some other platform, they get information. So they don't always get the right information. I mean, things about ChatGPT, and that was not discussed, they can also hallucinate. What does that mean? So maybe if you forget the poor performance, they can actually make up stuff. I mean, people know this, right? So they can make up a reference, they can make up a diagnosis. There are ways to try to guard them. So great technologies, but we also have to see that at some point there's going to be a public awareness issue because people are going to use these because it's convenient, it's going to give them something, and once in a while it's going to give advice that could be really bad, like delaying their care. So just understand this, I think, is important for all of us. Also at the time where a lot of population doesn't have that much trust in the institution, is an issue because really with all these tools, their strength, but also their pitfalls, we will need some truth source because any of us who have used, and I use the different versions of ChatGPT, they're great, but they also make significant mistakes. So, really summarizing the article, I think it is a very exciting area. I think that these technologies are gonna start helping us do healthcare better. How are they going to be integrated into real clinical practice is partly going to be regulatory. Actually, most of the devices right now that are approved by FDA, as far as I know, they're all the classic pathway. Although I know some companies now are looking at using these foundation models. Now, as experts for you, there's excitement there because if the right pathway develops, a lot of things are going towards codeless. So essentially you could actually make an application with no coding background. So lots of exciting things to come up, because in the future, not only just using images, but clinical information, we know these things do well, laboratory data to predict. So that was sort of what I have to say. I think there is an exciting future of a lot of advancements, but I think to deploy these safely, we need to think of all the facets and understand both the strengths and pitfalls of the technology.
Great. Thank you so much. That actually was I really enjoyed your perspective on this, and as well as your expertise. So I know Kyle has a question, so I guess let's leave the discussion with that.
Yeah, so I appreciate everyone's perspective, and I think this is a very interesting topic. I have a very simple question, which I think may be answerable, but I'm not sure. In this paper, the AI did a better job at identifying humerus fractures, distal radius fractures, kind of large bone fractures, and not as good of a job at scaphoid non-unions and sort of smaller fractures, and that even metacarpal fractures. And I guess that is somewhat logical, but I just wanted to kind of understand, if anyone can explain it, why that would be. Why can it not pick up a metacarpal fracture? I would think that would be similar to a distal radius if it just looks at the curvature of the bone, and if it's not if it's different than normal, you would expect it to pick it up. So can anyone explain mechanically why that's the case?
So I think this may be a question for Dr. Forghani, since you're a radiologist.
Sure.
Yeah.
I can speculate, and the authors may know better. If I go by the logic, one thing I can think about is how very large language models and now multimodal models trained exposure to lots of data. So they're going to do better where they got more exposure. So, and this is just speculation, is that likely there's more sources out there of some of these large bone fractures that made the algorithm more familiar. Whereas the smaller ones that not only may be more paucity, they may be more variance, and it didn't have enough exposure. So that's, I think, mechanistically, that's one reason I can think. It's ultimately a training issue, right? So if we really train something well, you're right. It should, and there are algorithms, by the way, that do fracture detection with high effectiveness. They're FDA cleared algorithms. So in my view, from a mechanistic point, that's the most plausible explanation. I don't know if Dr. Nolan might have a comment on that since they.
I'm certainly no AI expert, but I do believe that there's a lot more out there on distal radius fracture and humerus fracture in terms of probably images that are accessible to the model. And I agree. I think with you, it's a source volume issue is why it's able to identify those as opposed to nuances of the bone fracture itself.
That sort of implies, though, that as more data is input, that it will get better and better. And so the question is, when do we think the threshold will be met where then it's better than either a human or, when does it meet that threshold? And I also wonder whether, if you said that there are different, models for fractures, for instance, are we going to need different models for ligament injuries and for tendon injuries and nerve injuries? I don't know. I wonder what the experts' perspectives are on that.
Well, if we go by the way FDA does it, yes, right now. Unfortunately, the way FDA clears things is one by one. Some of us hope that, and look, I'm not criticizing the FDA. This is just, it's just in practice is becoming a hindrance. And we see that, right? Like if you look at in the Europe, where they use a CE mark, right? So there are products there that are quite good, comprehensive, that are not making it. And actually, for those of us who want to make something that actually has value to practice, including yourself, that's important. So the one-to-one is partly regulatory. I think in terms of training, it also depends. Are you specifically developing an algorithm or these general models? The general models, okay, so right now, they're just exposed to what's out there. So they're not going to be that good. So actually, the fact that the results weren't that good, it doesn't surprise me, and it follows logic, right? Where I think that there are going to be general models that are very good is some of the medical device companies, right? I don't want to name any because I don't want to be like a mouthpiece to try to promote any. They see the potential of this technology. So they're starting to shift, although like I said, I haven't seen it actually used to clear a device. They're investing in foundation models that are heavily trained on data. So of course, these ones are not just going to use a few images from internet that you're going to have that limitation, right? Because there's not going to be enough out there just as open source. They're going to start partnering with hospitals. They already have partnered with hospitals. Actually, Dr. Nolan is from Mayo. I have a few colleagues and friends there. I know that they work closely with some, so then those sources, chances are they will build, and you're likely, in my opinion, to have foundation models that are going to start doing these things much better. But that's going to be a training. It's just like us, right? In some ways, when you teach someone surgery, right, there's how many cases they do, but they get exposed. For me, how many cases I've seen, how many variants I've seen, it's going to be sort of the same for the machine. So I don't think the general ones are going to do that well unless we start to release massive data sources on the net that they can access. And that means like whole scans, right? But the companies focus on that partner with health organizations likely will start to have models that do very well.
So this is very fascinating for me because I think myself, like most surgeons, AI just kind of just crept up onto us, and then suddenly we find that everything is all about AI. I think certainly, in the field of radiology, you guys have really been on the forefront of using it, and the applications are very obvious. But I would love to hear the thoughts from the experts about where do you think AI is useful in surgery in particular? What I've seen in publications have been the usage in radiology, for example, or ChatGPT's ability to take in-service exams and education. But I'd love to hear from Dr. Foghani and Dr. Liu about where do you think AI might be useful for surgeons and hand surgeons in particular?
If you want, I can give it a go. So very useful. I think the multimodal is going to be a great tool for you because, I actually started in surgery, and I remember that long ago, someone told me the best surgeons are the ones who know when to operate and when not to, right? They get the best outcomes. And if you think ability to predict, and not only use just imaging data, but, other source, the technologies like ChatGPT, and right now they're, the things like Epic, the EMR is starting to allow some of these strong tools. They can summarize a whole chart in seconds, something we can never do. They can find associations we can't. More and more, they will get into predictive analytics. So I think it's very relevant because in terms of who should I operate on, who should I treat? Now, there is a caveat, and actually, I'm a big thing. I think the domain users need to be involved, right? I wouldn't design AI for like someone in oil and gas industry. So I always find it interesting what others do for us. You're the one who knows, working with the experts, right? What you need. But the one thing to think of, and Dr. Liu actually alluded to that. Remember, right now, the safe AI development, like in radiology, most tools, there's some biomarkers getting through the FDA, but the ones that are approved pretty much all have to be things that expert does. So sometimes you have to say, okay, does it have real value? And we won't, this is a long discussion. And then things that I can verify, if done as intended, right? If I do my job, I don't get too much automation bias. One of the issues, the exciting part, is that the predictive tools are going to be transformative because theoretically you make change therapeutic decisions. We don't have right now the mechanism to monitor those because this algorithm goes wrong, I have to overrun it. Like it calls something that's not hemorrhage or vice versa. I see, okay, it's a hemorrhage in the head. Once you start doing things that the expert can readily verify, there's actually, so people are working on these because it's not even just a simple algorithm drift, which means degradation over time. The ability to do that is going to be much more crucial. So we need to invest. So people are building platforms that allow QA. And how do you do these? So again, these are going to happen, but I think we need to think, sometimes you get all these like hyperbolic things about what can be done in healthcare. But if you think, it's not that it's not possible, but we need to think about these steps. And maybe Dr. Liu can, because she brought that up, which I thought was a very insightful thing about regulation. Maybe she can continue and comment on this.
Yeah, I'd like to give Dr. Liu a chance to comment, but thank you so much for your insight.
I totally agree with Dr. Foghani. Predictive analytics will be very useful, but yes, it's very hard to validate, to say, okay, because physicians are not really used to predict, right? And then it's how do you validate? And then also Dr. Foghani mentioned there is a performance drift. You will see the model once trained, once it's when they actually use it across time, it's gonna, the performance is gonna reduce because the patient population is changing, your clinical practice is gonna changing. That does actually change the data that you see, the model sees. So we have to watch out for the drift. That's where what I said, we need to do a post-implementation surveillance. We need to know when we actually need to update the model, right, with the new data. Do we need to retrain the model, or do we just need to update the model with the new information? Yeah, that's something we have to kind of develop a procedure process for.
Great. Thank you so much. So in the interest of time, I'm going to turn it over to Kyle, who's going to moderate our second paper.
Yes, and we are going to go on to that, but there is one question in the chat that I think certainly fits with both papers, but I think maybe we could talk about it for just 2 or 3 minutes before we get into it. The question is, what is the landscape on how these technologies will be seen from a legal standpoint? For instance, if there's a misdiagnosis on imaging, let's say, again, the metacarpal fracture or even the scaphoid fracture, and whether the physician who's using AI for this will assume the legal risk. I mean, that's a philosophical question. I wonder what, Dr. Liu and Ferghani, what your thoughts are on that.
I think this, yeah, well, go ahead, Dr. Ferghani.
Oh, go ahead.
But I think it's actually up for debate, right? Everybody's talking about accountability. Who is actually accountable for this type of decisions? It's I don't know, Dr. Ferghani, if you have a like insight perspective. Yeah.
It's not worked out yet, but it is something that people are focusing on. So for example, right now, a lot of medical device companies want us to approve. And it's funny because sometimes I've had colleagues who say, oh, our radiologist can be replaced. Most companies I know don't want to be the physician because they don't want to be pulled in every lawsuit, among other reasons, right? So, but whether that's escapable eventually, I don't know. And of course, we're talking about non-autonomous. If you have autonomous devices, that there are a few there, of course, they'll be liable. So right now it's there, but there are other ways AI is being used that I think physicians should know about. The power to just search, summarize massive data in short time. We're not the only ones who know how to leverage that. And some legal firms are also using this technology to extract information. So there are other ways that this technology is impacting the landscape. But I guess the short answer is we don't know, but there is interest in something that's going to work out over the next 5-10 years.
Great. Well, I'll just say that we as surgeons like to blame the anesthesiologists, so maybe we can find a way to blame them if something goes wrong. But we're going to move on to our second paper, which is entitled Experimenting with the New Frontier, Artificial Intelligence-Powered Chatbots in Hand Surgery. And so I'll ask Dr. London to begin sharing his slides, and we'll have a discussion about that.
Thanks, Dr. Evelyn, and thank you for the invitation. I'd like to start also by thanking my co-authors who've done a lot of this work, especially Zaid, who's a medical student at University of Missouri, and Dr. Kirby, who's one of our plastic surgery residents. So no relevant conflicts of interest to disclose, but I think we do have one that's probably applicable also potentially to Dr. Nolan's paper, which is the challenge of AI papers and the way publishing works is that this paper, I would say, is already out of date. It was just released in the recent issue of Hand, but with AI technology changing so quickly and constantly learning and updating, our study was replicated, and actually we are talking about doing this right now and replicating our own paper to see how things have changed in just a 2-year time frame. So our patients, like we've all experienced in our own clinics, are easily searching the internet for information, and they want to know, potentially even before even seeing one of us, what their diagnosis is, what their treatment options are, and what their outcomes may be. And Google and other search providers provides that information easily, and AI is now starting to play a role. Even if you type in carpal tunnel syndrome into Google, the first hit now is Google's own AI and its overview of what carpal tunnel syndrome is, what treatment options are, what kind of physicians you should be seeking care from. And this is what will be guiding a lot of our patients potentially before or after we interact with them. So with that in mind, we wanted to see how good ChatGPT as a large language model would be able to answer questions about basic topics in hand surgery. And so we crafted 56 questions regarding treatment options and care providers for common hand pathologies. Green's hand surgery was used as a general template and reference for what these topics should be. And we asked these 2 questions for each topic. What options are available for the treatment of blank pathology, and what specialist should I see for that blank pathology? So these questions were fed to ChatGPT, version 3.5, so an earlier version than what Dr. Nolan discussed in her paper. This was done between January 2023 and February of 2023, so already 2 years old from present time. So these answers were then reviewed by 2 fellowship-trained hand surgeons, and we were asked to assess the accuracy, completeness, and usefulness of the answer that ChatGPT provided. Descriptive statistics were reported on the basic values of the above, and then the agreement between the 2 reviewers was measured via CAPA scores. So in terms of our results, we found that the answers provided by ChatGPT were 80% accurate, 70% useful, and 57% complete. These are the individual numbers in the bar chart on the right between the 2 physicians. I believe I was Dr. 2, who was maybe a little more skeptical of the answers than my colleague. Because of those differences, we only had fair to moderate agreement in our views of the accuracy, usefulness, and completeness. Accuracy was the variable we most agreed on at 0.42 for a CAPA, which falls barely into the moderate level of agreement, while the usefulness and completeness fell into the fair category. For the specialist referrals, it was based a lot on the question. So for fracture care and things related to hand fractures or distal radius fractures, ChatGPT was recommending care in the emergency room or by an orthopedic surgeon. For other potentially more nerve-related topics, orthopedic surgeons were recommended, as were neurologists. For arthritis, that included then rheumatologists. Physical therapists and sports medicine physicians were also recommended for some of the tendonitis pathologies that we asked. What is missing is hand surgeon was not mentioned once, or plastic surgeon was also not mentioned at all by ChatGPT as a possible specialist to see to treat these pathologies. So what are the implications of our data? Well, one is that could be influencing our patient expectations. So the data that patients are seeing is mostly accurate and potentially complete and maybe useful or not, but there's also some of that incorrect information that was mentioned by the experts that these large language models can provide. So for example, when asked about distal radius fractures, ChatGPT stated that surgery was the most common treatment, when in fact about 80% of distal radius fractures actually are treated non-operatively. So this can impact our patients and maybe set their expectations before ever being seen by us, which then requires us as the physicians to potentially correct misunderstandings of what typical treatment options should be for the particular patient in their particular situation. The other place where this could play a role is with referral patterns. So hand surgeons and plastic surgeons are missing. And with that, if a patient's unsure of where they should be seeking care, that could be influencing who they end up contacting to seek treatment and potentially not having them see the best possible physician for their particular problem. And so with that, I'd love to hear any insights from our experts and enjoy the conversation that will follow. Thank you.
Thank you, Dr. London. I'll first ask Dr. Liu to provide some comment here and share slides.
Okay.
And then Dr. Furkan.
Okay, thank you. I think this is a great article where I think the most important message here is most responses of ChatGPT are correct, but the answers are some more precise answers are actually needed for patient safety and avoid misinformation. And then so this is alluded to actually the hallucination of large language models, where the hallucination might occur when actually whatever the content generated by the large language model are actually factually incorrect or sometimes nonsensical or inconsistent with the input, right? But it's actually often presented with a very high confidence. And there are different causes, right? Some of the potential causes are, for example, the probabilistic nature of the models, where it's predicting based on data, not actual knowledge. So it's all correlations, not the causal relationships between the variables. And also the training data limitations. Since this large language model are trained on the massive text data out there on the internet, there's really no control over what information is accurate, what are actually there are mixed of misinformation, biases, inaccurate information, incomplete information. And then so when the models are trained with these data, it will be biased, and then sometimes it will produce these hallucinations. And then also another reason is because large language models are deep learning models. They're what we often call black box models, we can't really tell what are actually the important predictors, so that we can actually kind of validate with our own human knowledge. So from my own experience in building AI-based clinical risk prediction models, I work in the clinical area of acute kidney injury. So I have built models for predicting acute kidney injury in the hospitalized patient population. I kind of, for the past 10 years, I have intentionally only used interpretable models like the decision tree, gradient boosting machines with decision tree as the base learner, or logistic regression, so these are all very traditional machine learning algorithms, supervised learning algorithms for classification. So I can do prediction for AKI. And also there are unsupervised learning methods for clustering, where we can look at for acute kidney injury, we can do a subphenotyping. But with the advent of large language model, ChatGPT, it's just so good. The performance with all the deep learning models are so good. So I slowly also kind of transition to looking into the deep learning models, where we're starting to explore autoencoders, for example, for patient representation learning, to actually better identify similar patients for their risk stratification. So basically, it's actually representing a patient based on the clinical variables in a very high dimensional space, where then we can do a better job at the risk stratification. And then but these deep learning models are black box. It's very hard to explain it. So we're looking into ways to explain it, to actually exploring also the graph neural network actually nowadays to model the longitudinal patient history, where we can have explainers to run after these algorithms to explain the deep learning models. But what the lesson I have learned through my research is that the quality and the quantity of the data is really the key for predictive modeling. The model is only as good as the underlying data that you feed into it, right? The data that you use to train the models. And then when we do machine learning and building these machine learning models for predictions, we often just throw everything what we can find in the EMR into the model. So we don't do pre-selection of features, but sometimes if actually we do a predefined list of features to build a model, it may be better because the model may be simpler. You can actually, data cleansing is easier. It's easier to explain. But the disadvantage obviously is also because if we're actually pre-selecting features, that means we're using expert knowledge, domain knowledge to select it. So we miss the unknown factors. So there are, trade-offs. And also based on what I have done in my research, I have also mentioned that rigorous evaluation of these AI models is critical. Right? Internal, temporal, external validations are required. And also we have, in our previous studies, we have shown that evaluation across diverse subgroups patients are really desired. And then, as I also mentioned, post-market or post-implementation model surveillance is warranted. And then lastly, the last message I want to say here is actually, should we choose a traditional machine learning model that's more interpretable for clinicians versus a deep learning model? Well, it's really depend on how much interpretability you would prefer for the task that you are in, right? And then versus the performance. So there's always a trade-off between the interpretability and the performance. Yeah. Thank you.
Great. That was very insightful. I wonder if Dr. Forgani can provide some comments on this paper, and then we'll kind of open up the discussion.
Yeah, so this really expands on a number of things we discussed for the last paper, right? So the performance is not that good, but probably not a surprise because this is a very specialized area and it just has not been exposed to that. I think as it was alluded to, and perhaps a good news, that was a 3.5. Now you have 4.0, you have the version, depending on your version of ChatGPT, there's a deep research version that's even more robust in checking. So the performance, and I'm AI editor for one journal, we are seeing the performance improve. But I think there's something to think about. Remember, these are general models. So chatbots could be very powerful in clinical practice if you have a team that develops them. But normally for something to work effectively, especially in a high stakes place like healthcare, you need to adapt it. So some of these because now you're just feeding something, you have not trained, validated anything. We would never deploy a medical device that way. And so I think that's a distinction we have to make. Not maybe these will eventually be used to create medical devices, but the hospitals that are using these, what they will do is that you need to put guardrails. There are different ways. Sometimes there are things called RAG or other, and you need to do that. Otherwise, you're just going to have bad outcomes and and potentially do harm. And of course, just for the general audience, if you're not very familiar, just also keep in mind the general version of ChatGPT. If you're doing your research paper, whatever, once you put something there, it's essentially an open source. Now, you basically the whole world, for practical purposes, it will be used to train. So again, healthcare organizations, what they're doing is, for example, they'll partner and they'll have a version that's both HIPAA compliant for patient, information, and also where your information doesn't get. So if you want to deploy, think about that. Very powerful, but danger. But it does also get to the other part. And even though I'm a radiologist, thinking broad is so easy to get an answer. And we're all so busy. It does concern me that you're going to have people consult these anyways, no matter what we say. Right. And with these kind of performances, we need to highlight really to the population that they may be getting some really wrong answers. And of course, you'll see some of the downstream effect because they're going to come to you and potentially also even challenge you or ask you, why don't you do this? Because they may have a misconception. So it's a double-edged kind of sword. I do want to share this one slide, which I thought was appropriate for this. And if you're wondering what this is from not the original ChatGPT, but it's OpenAI. So as a disclosure, created this. It's meant to represent HAL, which is a computer from the movie 2001: Space Odyssey. This is probably a young crowd, you may not know, but for those of us older, it's the 1960s movies, classic Stanley Kubrick, where that a supercomputer takes a spaceship to the space, then the supercomputer goes essentially crazy and starts killing the astronauts. That's the message. Actually, ChatGPT is respecting the IP. That's why it doesn't show the original for you, those of you who don't recognize. Why did I put that up? Because I think that's something we have to be aware of. AI is very powerful. It's going to change things. But as we deploy these very powerful technologies and make them widely available, I think we do need to realize, and it's not even intentional in these cases, right, that they will make mistakes. Some of these models are just probabilistic. They're going to say things that are wrong. They're going to say those things with high confidence, very articulate manner. And as a general thing, I think one thing not only for us as scientists, but also to the general public, is that we have to make them aware that these powerful technologies, as great as they can be, they can also potentially cause harm. It's something that I think will come more and more, especially in healthcare. But, for those of you who want to use this, I mean, chances are, by the way, your organization, there's some big organizations here, already has a version that's HIPAA compliant that you can use to train. Chances are it may be integrated into your EMR. There are ways to deploy these effectively and safely. And you can put guardrails. For example, you can limit the knowledge base they use. So they don't just go probability, okay, this is the best probability, so I'm going to say this thing even though I have no resource, right? Now, the good thing is some of the newer versions, actually, and I'm curious, Dr. London maybe has already looked into that, because some of the newer versions are starting to actually go and try to get reputable sources. In the past, it's great if you want to draft a text, but whenever it was something sophisticated, I would have to just correct. I am seeing it a little better, and I wonder if we're going to come to a point where even the general model hopefully will know that, oh, I don't know this, so I better not say something or get something from a reputable source. But I'll be curious if Dr. London probably has looked into this already. It looks like you're using the versions. Is it getting better?
Oh, I don't have an answer yet. I literally just came up with the idea of redoing the study last week at IFSSH as some AI papers were being presented and realizing just the different versions that were being shown. And so we are just starting the process of refeeding the same questions in, so we don't have any data yet to share. But I would also presume it's getting better. That would just be the logical response as it has learned more. My kind of curiosity will be by how much, and also what our perceptions are as the hand surgeons evaluating those answers.
Yeah, Dr. London, there's some questions in the chat, which we'll get to, but I wanted to ask you a philosophical question about this exact article. So you used ChatGPT, but the truth of the matter was what the two surgeon reviewers thought, right? And so there was not perfect concordance amongst the two surgeons. And so my question is philosophically, what happens when the ChatGPT or whatever is being used gets better than the surgeons? And if we as surgeons are using our knowledge as what the ultimate truth is, there may come a time where there's an inverse relationship and actually they're more accurate than we are. It didn't seem like that in the study, but what are your thoughts about that? And what were you expecting to find?
Yeah, no, it's a great question, Dr. Eberlin. I think that is a potential, downstream effect where the computer does become, or ChatGPT or whatever model you use becomes like Hal and potentially knows more than we do as the treating physicians. I think we still hold the ultimate sway as the one who holds the knife or the needle or the cast or what it may be, whatever it may be for that treatment. So until ChatGPT becomes autonomous enough to do that, I think we're safe to a certain extent. The discordance in the agreement was a little bit of surprise. And some of it also came down to just some simple nuances of understanding what we mean by accurate and comprehensive and useful. And so, some of it was, some answers were there, but not all, or the answers were very vague in the sense of, I think one example was like kind of, you have a flexor tendon injury. It was like, you should potentially have surgery. And so, would we consider that to be comprehensive and useful for a patient? And so I think some of that was just the different perspectives of the reviewers in that regard. Now, in theory, as it gets more complete and robust, we could potentially get more. And it's also a question of you ask the follow-up questions. And, I think an interesting study could be letting patients loose in a controlled environment with talking to ChatGPT and seeing how they interact with it. Take a bunch of carpal tunnel patients and have them, type into ChatGPT prior to the visit about carpal tunnel or after the visit and see, how far do they ask questions of after they get the initial responses like, okay, surgery is an option. Well, what if I do have surgery, ChatGPT? What should I expect my recovery to be? And how many questions deep does the patient go, and how do those answers then get modified as we kind of go down the treatment algorithms to a certain extent?
I think this also highlights an important thing about ground truth, as I sort of alluded to before. When you train things, there's some things that are going to be concrete, like tumor is this. But there's going to be other things where, where we're not that good. Take back pain, right? Where we're not that good in predicting. One could foresee eventually the machine truly augmenting us, right? So not just doing what we do, but actually being an addition that makes us better. But the way to do that, and the only way to do that, one is, of course, right now, people, when there's variation, they use multiple experts, consensus in radiology. We do this as segmentations things. But in the long run, it's going to be tied to outcomes, right? So if you get a lot of patients, you have the outcome trained. But this is also a big leap. Remember, machine learning learns with experience, but that's not how we deployed in practice, right? That's not allowed for good reasons. It could go crazy and we don't have ways to control it. You would need feedback loops. So I think these are the things when we think of AI, true AI, we need to also think of these build infrastructure, but there may come a time, but I don't think it's going to be for everything. And honestly, I think like every other technology, we can do better. Think of all the robots you use and how they're going to help you. It's just going to change the way we do things. I think if you always want to do the things, whether it's a radiologist or other clinician, the way you did it, you're a threat. But these things are going to open, in my opinion, tremendous opportunities for enhancing patient care. But we do have to think also of the true implementation, which sometimes is overlooked in terms of these feedback loops eventually that let us do the big things that I think could actually be revolutionizing for medicine.
And the feedback loops is a great point. I saw a presentation just last week at XSH by the Hand-Wrist Study Group, which for those who aren't familiar is a large kind of conglomeration of clinicians and researchers out of the Netherlands, where they had done some predictive modeling using AI about patient outcomes after surgery. And the question came up during the session was, so are you improving upon this? Like as more surgeries are being done by all of your surgeons and you're getting more data, are you updating the model? And as an individual institution, they don't have the bandwidth to do that. So the answer was no. But that's the key, is to get the models being continuously fed with that feedback so that if it is for a very specific question of clinical outcome and predicting who will do well and who won't, we're constantly learning with the model as the model is learning with us.
So I have a quick question I'd like to ask Dr. Liu that kind of relates to what was were being talked about. So I think some of us are familiar with Moore's law, when computing, the computer power increases every 2 years exponentially. So in your opinion, do you think the technology in AI and the accuracy of AI will increase that way as well? Or is what you have seen that the technology relating to AI is increasing in a more modest pace?
I think it will probably also grow as the pace as the computing resources that we have, right? Because especially with the large language model, I mean, it has really transformed the entire machine learning community, actually, right? So it's because before we were always building specific models for specific disease. Now it's a foundation model. And then also I saw in the chat asking like with the AI optimization, where with these foundation models we can pre-train. It's pre-trained foundation models, and we can always fine tune to a specific field. And I think with the pace of the ChatGPT and all the other large language models, the accuracy it's growing at a very, very fast pace right now.
So I know I don't do I know it's hard to pin down like when ChatGPT will become more accurate. But when we look at a lot of the papers, I think a big problem is the main conclusion for most papers is that ChatGPT is great, but it makes mistakes. So do you have a timeline as to when do you think you'll get better to the point where we could use it reliably in medicine without, thinking that you'll make a lot of mistakes?
Well, it's just my opinion. I think maybe within 5 to 10 years.
Oh, that's
Yeah.
great.
It
And also
depends if
one-
you're exposed, but there's a legal thing, right? Sorry, there's a regulatory thing. Because right now, if we use it, and that's almost the scary part, because it seems that regulations behind. By regulation, if you're using things, especially something that analyzes pixels or any type of information from medical, it has to be reviewed and cleared by FDA, and we're not. So this opens a whole other thing. And when does FDA come in? It's a very interesting topic, but I think we'll need some reforms and clarity there.
Thank you for the comments from both of you. There's one more question in the chat that I think would be nice to address, and I think that you talked about briefly, Dr. Liu, but Dr. Baxi actually mentioned that there's search engine optimization available when you do a Google search, for example. So is there something similar for AI that can be used to kind of filter the information that's fed into AI to make it more accurate in general?
I don't know. I'm not aware of any well, I know there are people working on foundation models where currently with the large language model like ChatGPT, it's trained on tremendous amount of data and also using tens of thousands of GPUs. It's very expensive to train, right? But there are people working on ways where actually, if we are able to filter out the data, make sure we have a high quality data, then the amount of the time and the computing resources needed to train an accurate large language model is actually significantly lower. So filtering data is definitely helpful.
You can tie it to a corpus.
Mhm.
So that's one way. So for example, you can create a knowledge base, and then you get the sort of the generative, the ability to analyze, but limit what it can say. So that's it's not quite filtering, but it's one way among different.
Yeah, we can utilize the medical terminologies and the ontologies. Those are medical knowledges, evidences we can actually inject into the model, try to constrain the answers so that it's actually more concise.
Great, thank you so much. So I'm just going to end by sharing some slides. So again, I'd just like to remind everybody that CME can be claimed for Hand in Focus every 6 months for all AHS webinars. And thank you very much for your participation. Please follow AHS on social media, and candidate membership for trainees is free. We have a very active social media presence for the Hand Association. And please watch out for our next journal club. So again, I'd like to thank all our participants tonight, our authors and our experts. Thank you so much for the insight. I think for me, as a surgeon, my day job is to operate and see patients. I really learned a lot, and I think all of us did as well. So we really value your insights on this. And of course, I'd like to thank our participants as well for their great questions. Thank you so much, everyone. Have a great night.
Thank you.
Thanks,
Good night.
everyone.
Bye.
Good night.
Thank you.